than 2 years. And this is, many patients might present you taking auxiliary, as we said, less than 2 years. It's a screening, and sometimes it's misleading also. So if there's no contraindication, your patient is not, leukomic, and you think that his platelet and maybe he has, some coagulopathy, it's recommended that you take a rectal temperature. And we do take for the, patient who present to the ER. Now, if we had a trauma patient and found he's pale and we have time to cross match, now it depends on your institution, Aisha, in your, where you're working. But if you have a patient, pediatric, and he is meeting the criteria for massive blood transfusion, or he needs, emergency blood transfusion, you could use O negative based on your hospital policy. If this is, meet the criteria as we set for emergency transfusion. If the time permit, yes, it's better to have a cross-match blood. But if the time does not permit, you can use O negative for your patient. Now, Iman said the nurses are afraid from doing rectal temperature. They have fear from injuring rectum. It's a safe procedure. Might instructor do some teaching in your hospital how to do it, not to go deep, okay, not to injure. Use a loop for the babies, and it is, many times we discover patients that they, nurses, they do axillary, and when you do a rectal, you find, that the patient is 39.5. So, and this is the first visit. This is the first time when the patient presents to the ER. So you need to document what is, patient's, vital signs. So if you document that he's a fever, this is where you're gonna treat your patient and you think about sepsis. But if you think that the patient's temperature 36.5 febrile, you might miss, sepsis in somebody who's less than 1 year. So if there's no more questions, we'll close this session, and we'll give you 10 minutes before we start the next session. Thank you very much. Can we stop? Okay. You guys, I guess I was mute. Now you can hear me very well, I guess. So you did not miss anything. So go back again to the, defining the definition of sepsis. So it's a leading cause of morbidity and mortality in pediatric population. If we're talking about numbers, globally, there was 22 cases, in childhood per 100,000, person a year. And we're talking about 2,000. And you see the difference when you're talking about neonatal sepsis and how it's very important, for us as a triage nurses, to pick up, and give high priority for, neonatal when they arrive to the, to the emergency. There's 2,202 cases out of 100,000, live birth occurs. The majority of children who die from sepsis suffer from refractory shock or multiple organ dysfunction syndrome, with many deaths occurring within the first 48 to 72 hours. Now, why are we talking about that? Because the early identification and appropriate resuscitation and management is very critical, for the outcome and the, that can the care that can we provide it earlier, detect patient earlier, we can have better outcomes, and we can have, globally we can improve the number of patients who are, can be discharged from ICU, can be, not part of the, morbidity and mortality rate in the world. So what happened exactly, about this, special article? Are you still not hearing me, guys? Do you hear me? Okay. So the design of this, study happened that there was 49 international experts, pediatric, consultant between emergency and ICU, representing 12 international organizations, and there was a panel, and they met in November 2018. Type. Again, guys, sorry, do you hear me now? I remove even the mic. Is it okay now? So let's continue. So they have that meeting that happened in November 2018, and their, objective was to come up with a recommendation for the clinician how to treat and to manage pediatric patients with different age-specific groups when they're presenting with septic shock, with organ or without organ dysfunction. There was a discussion about, recognition, management of infection, hemodynamics, resuscitation, ventilation, endocrine, metabolic therapy, adjunct therapy, and research priorities. So these are the topics that they discussed about early recognition, management of infection, hemodynamics, what medication, what vasopressor they have to use, and resuscitation methods, okay, what fluids, ventilation, metabolic therapies and endocrine, and the adjunct that can be used, and what is the future, priorities that they have to look forward. Now they come, what is the result? What is the result? After they make like, 6 subgroups about recognition, management, hemodynamics, resuscitation, ventilations. They made a systematic review for each population, intervention, control, outcomes, and they classify this recommendation based on their, about is this recommendation weak recommendation, if this is strong recommendation, if this is good for the practice. So they use evidence to decision framework, formulate recommendation as weak, as strong, or maybe has no relationship with the practice. So they come up with 77 statement on management, resuscitation of children with septic shock and other sepsis associated with organ dysfunction. Now, overall, 6 were strong recommendation, and there were 52 were weak recommendation, and 9 were best practice statements. So that is the total, recommendation that they come up. And there was only 6 that are strong, and 9 were best, practice statement. We will go in deep and discuss this, stuff. Now, the conclusion that they come up from this, meeting, and this was able to achieve consensus regarding many recommendations for best care of children with sepsis, acknowledging, and that's the most important thing, most aspects of care had relatively low quality of evidence, resulting in the frequent issuance of weak recommendation. And this is what they were pointing out, that most of the recommendation that is in treatment of sepsis are weak recommendation, does not stand in a good evidence or strong evidence that can be recommended for the treatment. They have changed also the definition of sepsis. So we have all definition of sepsis, like sepsis was in the old considered as a life-threatening organ dysfunction caused by dysregulated host response to infection, and septic shock, the subset of sepsis with circulatory or cellular metabolite dysfunction associated with higher risk mortality. So they changed the new definition as septic shock in children as severe infection leading to cardiovascular dysfunction, including hypotension, need for treatment with vasoactive medication or impaired perfusion, and sepsis associated with organ dysfunction in children as severe infection leading to cardiovascular and non-cardiovascular organ dysfunction. So they have changed the sepsis and the septic shock definition. Now, what there was, intention, their intention was to apply these guidelines to all patients from greater than, 30 weeks, okay, gestational age, shock as defined by two International Pediatric Sepsis Consensus Conference, or inclusive for severe infection leading to life-threatening organ dysfunction. Now, this is again, depends on in your this panel or the campaign itself have left, a wide, range for the different institution and hospital to use their, their preferred, screening tool to screen for patients who are for sepsis. Now, in children who present with as acutely unwell, we suggest implementing systematic screening for timely recognition for septic shock and other sepsis-associated organ dysfunction. Now, this is a weak recommendation, very low quality of evidence. This is what they come up with. Now, however, based on your hospital and what you are in your hospital, what screening tool that you are using in your hospital to, catch patient who present to the ER with sepsis. So different hospital, different, tools. It depends what tools, what type of patient you are treating. Are you treating mostly healthy patients, non-complicated patient, or you are taking care of tertiary patients where you have to adapt, different tools that match your population in your hospital. So that was left to the hospital institution and to decide what screening tool that you are using to catch patient with sepsis. And they have also said, although the optimal method or tool for screening is unclear, we suggest that screening tool has to be adapted to the type of patient, resources, and process with each institution. And this is again, as I said before, each hospital, pediatric department has to decide, when it comes to that pediatric department and pediatric emergency department, they have to decide which tools, match their population. So if you are really dealing with a lot of, tertiary patients, comorbidities, so you better use different tools. If you are using a healthy patient, also you have using different tools. So this is was left to the each institution based on their resources, based on their patient presentation and history. Again, back to the tool, which is the importance that you have to have a tool in order to catch up the sepsis. Sepsis can develop and become septic shock. And all of you know that, yes, pediatric, they tend to compensate very well, but at some point when they fail to compensate more, they they decompensate, and it will be hard to bring them back, unlikely the adult. Okay, yes, they don't decompensate very well, but they can come back easier than the pediatric. So providing the fact that, pediatric compensate very well, they give us as a clinicians, as doctors, as nurses, time to discover, okay, the sepsis before it happens. And that's why you have to adapt or choose a tool that can help you screen patient when they come to the triage. So systematic screening need to be tailored to the type of patient, resources, and procedure with each institution. Evaluation for the effectiveness, sustainability of the screening should be incorporated as a part of this process. I'm trying to just check, please, again, the voice, is it okay? Somebody, said the voice is not clear. Okay, thank you very much. So again, I will emphasize in this one. So the message that I want you to take it home today, if you have no tool at your hospital, please adopt one of the tools that can help you and help your institution to discover and recognize early sepsis. Because, if you manage, as we said, remember the first slide, we said, mortality rate happens between the 48 to 72 hours. So if you manage to detect sepsis before it happens, that means you will have time to treat sepsis. Now, rationale. What's the rationale to having, a tool that can help you to detect sepsis is systematic screening, for sepsis in children is driven by the premise that earlier recognition will lead to more timely initiation of therapy, which will translate to improve morbidity and mortality. As just, I said previously, you have 48 to 72 hours, and this is the time that you have. Now, if you manage to detect sepsis, and before the sepsis starts, to kick off in the pediatric patient, you will have time to manage to treat and kill, the pathogen and control. And remember, if let me take you back to the history about, the guy who invented the chess. The guy who invented the chess, he is an Indian, wise man. Once he, invented the chess, the emperor of India asked him, you can get, whatever from our treasures, gold, you can get diamond, anything you can get from our treasure. But the guy refused to take any of these, treasures. And he asked the emperor to give him, to fill the chess square with the grains. And he asked him to double this. So if you put in the first square of the chess, that there's 65, 64, square in the chess. So if you put in each square, double the number. So let's say number 1, you put 1. Number 2, you're gonna double it and make it 2. Number 3 square is gonna be 4. Number 4 is gonna be 16. Number 5 is gonna be, 16 by 16, I don't know how much. So and so on till you fill the whole square of the chess. And the emperor laughed at him, and he thought that it's a joke. It's gonna be an easy thing to fill the square of the chess within 1 hour. But the guys who's taking care of the grains and wheat in the Indian emperor, the second week they came to the emperor, and they barely reached to the square 32, and they finished all the grains in the emperor. So this is exactly, what we call it exponential duplications. Once the pathogen, enter the child bloodstream, okay, or enter the body, it has exponential, duplication numbers of pathogens. So if you have one bacteria, it quickly, duplicate the numbers. What to stop, the duplications or the exponential duplication of this pathogen is the early recognition, and starting the treatment is the antibiotic. So if you're able to detect the sepsis earlier and start your antibiotic earlier, this will stop the duplication process for the pathogen. Now, what is that you need to do in order? Now, we know that, you do the full septic workup for your patient, but we're gonna consider about some stuff that, that they mentioned in their, campaign, which is blood lactate. They said blood lactate levels provide valuable indirect marker of tissue hypoperfusion, although increased lactate levels are not specific. So it's not specific to hypoperfusion state. They provide quantifiable surrogate of tissue hypoxia and can be rapidly obtained by point-of-care testing available. So they are a readily, quickly result. It can tell you about the hypoperfusion or decreased perfusion to the tissue. However, they are not so specific to the sepsis. But if you have a VBG analyzer, you can do a VBG, get your lactate right away. Now, they mention in one PICU study, the mortality rate for children with hypotension requiring vasopressor with lactate greater than 2 millimole per liter was 32%. To compare with a 16% if lactate was less than or equal to millimole. So if you look into the percentage of, mortality rate, which is 32% if the lactate is more than 2. And if lactate is less than 2, you see the mortality rate, being cut off to the half, which is 16%. And this is tells you exactly, that when the lactate is high, there's a hypoperfusion state, and you try to bring the lactase, the lower levels, you will decrease the mortality for your patient. Final word about lactate should be therefore interpreted as part of more comprehensive assessment in clinical status perfusion. So this is the recommendation. Should not be taken, solo. That is the only indicator for the sepsis. Yes, you might have somebody who's having high lactate, but you need to investigate more if he's septic or not, or if he has sepsis ongoing or not. Blood culture remain the only, uh, the only, lab test that can be done, to recognize the pathogen or the microorganism for septic patients. And this is the golden, test. However, most studies have a focus in a timely delivery bundle of therapies, and this is example blood culture, fluid bolus, and antibiotic. And we recommend obtaining blood culture before initiating antimicrobial therapy in situation where this does not substantially delay antimicrobial administration. So if it does not really substantially delay the antimicrobial administration, yes, do blood culture. If the time does not permit for you and your patient is very sick, initiation of antimicrobial therapy take first, and you can start the antimicrobial therapy for your patient. But the golden rule, do it if the time permit. Now, what about other cultures? If we're talking about, urine culture, respiratory cultures, CSF cultures, tracheal aspirate, any other type of culture, these cultures should also happen as soon as possible, and depending on the suspected site of infection, such as specimen may have higher yield of pathogen identification than blood culture. So if you think at the meningitis and you think, taking gram stain culture from CSF, take a priority, this should be done as soon as possible. Now, the bundles, when it comes to the bundle in children with septic shock, they recommend starting antimicrobial therapy as soon as possible within 1 hour if you have somebody who has septic shock. This is strong recommendation, very low quality of evidence. Although it has a strong recommendation from the panel, from the committee, from the meeting, but it has low quality evidence. Now, antibiotic. When it comes to the antibiotic, they recommend to use empiric broad spectrum therapy with one or more antimicrobial to cover all likely pathogens. Once the pathogens and the sensitivity of the culture, became readily or available from microbiology, they recommend, narrowing the empiric antimicrobial therapy and keep it, to the sensitivity of the cultures. In children with sepsis-associated organ, sepsis is not septic shock, but is associated with organ dysfunction, but without shock. Remember, this one is without shock. They suggest starting antimicrobial therapy as soon as possible after appropriate evaluation within 3 hours. So you have a bundle of 1 hour and you have a bundle of 3 hours. So if it's without shock, you have a window of 3 hours where you do all your labs, your investigation, your blood culture, your cultures, other cultures, and septic workup, and you have to give the antibiotic. And again, this is a weak recommendation from the panel, and it has a very low quality of evidence. Now, what do we mean by empiric? Just to define this as they defined it, it's the initial antimicrobial therapy started for suspected infection in the absence of definitive microbiological pathogen identification. So when the physician has no idea what kind of pathogen, they will start empiric. So, and this is, has no definitive, microbiology pathogen. When talking about broad spectrum, this is, antimicrobial regimen with activity against multiple different groups of bacteria and other pathogens considered to be likely causes of the clinical presentation. So he has, some thought that this is the clinical, this, microorganism might cause this clinical presentation for this patient. And I will use a broad spectrum that can cover, specially group bacteria that is causing this special, presentation. But in the first one, as we said, empiric, he has no idea, he has no thought, he did not, this is empirically, and this one, he has some, clue that this is the pathogen can be considered or responsible for this clinical presentation, and this type of antimicrobial therapy, it can cover certain groups. How to start? The initial choice of empiric antimicrobial should be taken into account specific clinical history. Example, age, the site of infection, disease state, comorbidities, indwelling devices, what kind of devices the patient have, a central line, have a Quentin, has, PIC line. Patient with recent current hospital exposure should be received empiric therapy that consider non-infection or colonization. They have just discharged from the hospital, as well as any recent antimicrobial exposure. So the history, the age, and the previous pathogen play major history or a role in prescribing the empiric one. Now, they also mention about immunocompromised patients. They present in the hospital, acquired sepsis. Antimicrobial therapy should begin with anti-pseudomonal third or higher generation like cephalosporin, cefepime, or broad spectrum carbapenem or meropenem or imipenem or celestine. So these are the kind of third or higher generation cephalosporins. If the child is healthy and he's not immunocompromised with a community-acquired sepsis, he's not been hospitalized, he did not get it from the hospital, third generation cephalosporin like ceftriaxone may be sufficient. Vancomycin should be added to the setting where MRSA or ceftriaxone resistance pneumococci are prevalent. In addition of aminoglycosides or substitution of carbapenem is appropriate setting where ceftriaxone is resistance in common gram-negative bacteria. Now for neonates, should be also include ampicillin, okay, in consideration for empiric cyclovir if there's any clinical for herpes simplex virus. Now, when it comes to the fluid, they can also, they recommend that in a healthcare system or intensive care unit or emergency, they suggested administering 40 to 60 ml kg in bolus fluid, okay? 10 to 20 per bolus, okay, over the first for first hour, titrated to the clinical markers of cardiac output, and discontinued of the signs of the fluid overload. So this is again taking if your patient is cardiac, if he cannot tolerate, fluid, you're gonna make your fluid, cut it down, okay? And if your patient is can't tolerate, you go up with the higher dose. That's for the initial station for children with septic shock and other sepsis with associated. Again, this is a weak recommendation by the committee. This is a low quality evidence. Now, when it comes to the also in healthcare system with no availability of intensive care, in the absence of hypotension, we recommend against bolus fluid administration while starting maintenance fluid. So if your patient that you don't have an ICU, let's say you work in an area where there's no ICU, you cannot monitor your patient for overload, you don't have advanced hemodynamic for your patient or even basic hemodynamics, they recommend not to start, a bolus for your patient if he's not hypotensive and start him in a maintenance of fluid. In healthcare system, when no availability of intensive care, if hypotension is present, we suggest administering, 40 ml bolus fluid, okay, per kg, 10 to 20 ml per kg, okay, as a bolus over the first 4 hours. Again, titration to the patient condition, to the clinical status, and discontinued if there is any signs of, overload. What kind of fluid they suggested? They suggested using, balance or buffer crystalloids rather than 0.9 saline for the initial station with children with septic shock, other sepsis associated with organ dysfunction. Again, this is a weak, recommendation, but they come up with this, that using buffer and ringer lactate. Hemodynamics, they were not able to issue any recommendation about whether to target mean arterial pressure at the 5th or 50th percentile for age children with septic shock or other sepsis associated with the multi-organ dysfunction. However, in their practice, they target MAP between 5th to 50th percentile or greater than 50th percentile for the age. So they haven't decided what is the best, but they put from their practice is the best is to use the MAP as indicator for the between 5th and to keep MAP between 5th to 50th percentile or greater than to monitor the blood pressure. When it comes to the vasopressor or the inotropic, they recommended using epinephrine rather than dopamine in children with septic shock. They're suggesting also using norepinephrine rather than dopamine in children with septic shock. And again, these are their recommendation, might be very low, but this is, as we said, they don't have enough strong recommendation. Most of their recommendations were weak. Now, they were unable to issue recommendation for specific first-line vasoactive infusion for children with septic shock. However, in their practice, they select either epinephrine or norepinephrine as a first-line vasoactive infusion, guided by the clinician preference and patient condition and the systemic factors. That's most about the sepsis guidelines and campaign and their recommendation. If you have any question, please. I will go to the Now, Iman asked a question about, the screening tool that you can use for the sepsis. Now, different, as I said, different institution, different tools based on your patient population and resources. However, I'm just, sharing experience. You might have a tool that can be, based on your physiological, observation for your patient and based on the, lab tests. So in our triage, we have both. We have something called SARS, which is, when the patient can, alert can be fired in the system if your patient have, systematic inflammatory response to infection. So once your patient, child, present to the triage, if based on the heart rate, based on the respiratory rate, okay, uh, these are physiological, measurement. Based on this, you can get some idea about, if the patient is really having SARS or not. And the system will fire SARS if he has, three, alert or three criteria, it will fire SARS. Now, when the system will fire sepsis to, alert, the clinician, the nurse, and the physician, if you have like, two SARS criteria and one sepsis. When we're talking about sepsis criteria, we're talking about, blood pressure. We're talking about lactate. We're talking about, white count. We're talking about temperature. We're talking about bilirubin. So there are certain criteria that to measure sepsis and fire sepsis alert in the system, okay, and fire SARS alert in the system. And once you have, based on the physiological and based on the, blood test, you got this together, you might have a sepsis alert in the system, and this is goes to the physician and goes to a nurse to alert them that there's this patient might be, a possible he's in sepsis, so go ahead and do your septic workup and start the treat the patient. So that's an early recognition tool for your for the sepsis. Again, this is not, uh, there are different types, different tools, different modalities that hospital use to recognize and early recognition of sepsis. But that's, the best way to treat sepsis and prevent, decrease morbidity, mortality in children in unit that they might affect, them. Now, again, Aisha, you're right about your explanation for the broad and the empiric. And Walid asked very question about the CRB and, titer can be strongly dependable. Now, mentioning, the test and what they're looking for in this campaign, they haven't mentioned about the CRP. And as I told you, they haven't mentioned about, yes, CRB, a lot of clinicians use it, but I'm bringing, this is, an article, and this is, about, sepsis guidelines campaign, and they haven't mentioned about CRP. And regarding, septic shock and, waiting for chemistry to check if the patient have, abnormal kidney function or abnormal potassium to give, crystalloid or to give, to give, sorry, buffer or balance in comparison to use wrinkle lactate. I think you can get a quick VBG. You can know about your patient electrolyte as soon as possible and decide if you want to give, buffered, or crystal or normal saline for your patient. Again, this is not my opinion. It depends, that is their practice, that they prefer to use balance, until it's contraindicated for the patient, or patient have some abnormal renal function or abnormal potassium. If we have no more question, I can close the session. Again, thank you very much. Happy, to be with you, and wish you the best. Enjoy the rest of the day, and see you tomorrow.